This program is brought to you by Emory University.
Good morning, everyone. Welcome to Cardiovascular Grand Rounds. We have a real treat today in that Tom Porter is here from Nebraska. He is a professor of medicine in the Theodore Hubbard Distinguished Chair holds the Theodore Hubbard Distinguished Chair of Cardiology, and he's the director of the non-invasive lab there. Dr. Porter did most of his medical school training and undergraduate in Nebraska. Went to MCV for residency, and has done a little bit of training in some other places along the way, but largely has been at Nebraska for many years, and many of you are very much aware of his work in contrast ultrasound. He has really been a major, if not the major, contributor to that field. He has been well supported by both National Institutes of Health and industry funding throughout his career. Served on all of the obligatory and sometimes demanding committees of AHA and ACC, and has really been a major contributor in that area as well. He's a respected educator. He's won numerous teaching awards in Nebraska and was Department of Medicine Teacher of the Year award again this year, apparently. His productivity has been absolutely spectacular. He has over 200 publications, book chapters, many of them in the area of ultrasound technology, holds numerous patents in this area, and as I said, has really been one of the key developers of the field in contrast echo, and has really now been pushing the threshold of this into the therapeutic area. So we're really very honored and pleased to have you with us today, Dr. Porter. Welcome.
It's an honor to be here and at this prestigious institution where you can have the opportunity to talk about this and get interaction and feedback. And so I look forward to any feedback you have, and you feel free to interrupt at any time during the talk as well if you have questions. But the main thing I wanted to bring out this morning is where we are at with what we can now refer to as ultrasound enhancing agents. This is the FDA right now has only approved ultrasound contrast, or what we call ultrasound enhancing agents, for left ventricular pacification. If the windows are poor, that you use it for that indication, or if you have the failure to see all the segments in a 17-segment model. But there are other applications. Tomorrow we'll talk at the ECHO conference about the myocardial perfusion application. But today I wanted to just talk about the use of it for the FDA-approved indication, and then its potential where certain countries now are beginning to use it for targeted thrombolysis. The same ultrasound-induced cavitation that creates imaging can also, that cavitation force has been used to dissolve thrombi, and for targeted DNA delivery. Although this hasn't gotten to the point of being in clinical trials yet, it's getting very close. Get that to move forward there. There we go. I'll just use the mouse. And so, like I said, the main thing that we're trying to get the United States to get more involved with is using contrast for its FDA-approved indication. We have published guidelines on this that were recently in Journal of American Society of Echocardiography, which have emphasized that we want to inform both sonographers and physicians on the software and techniques to enhance technically difficult echo images. In other words, whenever it's necessary to see all the segments, and that's, as you know, become more and more important for stress echocardiography to have improved quality in this area in terms of getting detection of coronary artery disease. Also, it's important to see all segments when evaluating chest pain in a non-diagnostic EKG in the emergency department, or in a critical care setting where you're trying to rule out a regional wall motion abnormality. Similarly, when you're trying to do ejection fraction, it's important to see all the segments because of the quantitative nature of what we do there in terms of following chemotherapy patients or assessing for AICD therapy. And then when it's necessary to visualize the apex, this is where we see a lot of circumstances where many diagnoses are made are missed because of inadequate visualization of the apex. And I'll show you some examples of that. But in all of these settings, enhancement is recommended by the guidelines committee if you cannot see all the segments. Now, the modalities that you use to detect this are two different ways on your scanner. One is satisfactory, the other is much better. The typical way that's used is just to turn the mechanical index, or the power output of your transducer, down to less than 0.3 and use this B mode imaging to better detect the microbubbles and enhance border delineation. Unfortunately, that's still destructive and probably doesn't get the maximal signal enhancement from the microbubbles that is potentially available. Nonetheless, it has worked very well and helped us in many circumstances. This seems to get slower and slower every time we play it. But this is an example of a patient where recently we had a stress echo and this was before we were using the very low mechanical index imaging techniques. And the resting images looked pretty good, okay? But the sonographer was a little concerned about the distal septal and apical region, which is playing very slowly here. And when we looked at it with contrast then in that setting, in this case with the intravenous Ultrasound, it became much more evident at a faster frame rate here, the distal septal and apical wall motion abnormality. Again, you can see this was initially read as a normal, but when we use contrast, the distal septal apical wall motion abnormality became much more apparent. I was told this was going to buffer and be faster. It's got this buffering and being slower right now. So it may not be quite as evident there at this 5 hertz frame rate, but when it's at the real frame rate of 31 hertz, you can really see the distal septal and apical wall motion abnormality with contrast using low mechanical index imaging here that was not very evident without contrast. Even though the window was pretty good. It was pretty good. And again, these are examples where you could probably make the case that you might not need contrast here. And this is that 3-chamber view in that same patient. Again, you can see just using a 0.3 mechanical index with a B mode, you can better delineate the apical wall motion abnormality and more clearly identify the number of segments that are involved, which is critical when you're doing stress echocardiography. And this is the accuracy trial, which was published a few years ago, looking in dobutamine stress echo patients, where they used that low mechanical index imaging in a little over 100 patients, where they did a dobutamine stress echo without contrast, then with contrast. And you can see the number of segments visualized with contrast was significantly better, just like you saw in that example, at rest and especially during stress. And this improved the overall accuracy of the test in detecting coronary artery disease. And then in a more realistic setting of the intensive care unit, surgical intensive care unit, inpatient wards, outpatient setting, this was used, low mechanical index imaging was used to see how well does it change a technically difficult study, which is shown by red here, into an adequate study. And this is a study where the referring physician was called after the regular echo was performed, and then called again after the contrast-enhanced study was performed to see if it changed anything in the decision-making of the physician after the study was read with contrast. And you can see the number of technically difficult segments, or this is the number of technically difficult studies, was significantly less after the use contrast. Blue represents adequate studies. And more importantly, this really changed the way we look at how contrast impacts just your daily care of the patients, in that when they made that second call to the referring physician, they avoided additional diagnostic procedures in 32% of the 632 patients where they did this study. Drug management was altered in 11% after the contrast study. And a significant impact on the patient care was seen in about 35% of the patients studied. And it actually resulted in a cost savings of $122 per patient to use contrast in that early setting in terms of avoiding downstream procedures. And this led to an inter-society accreditation mandate that contrast should be used in at least 20% of the echoes. And we find that actually we're using it a little more than that, especially in the intensive care unit and surgical intensive care unit patients where you can't turn them on their side, and yet you're still required to give a very good ejection fraction assessment and regional wall motion assessment. And as I said, we have an even better modality than the low mechanical index imaging technique. It's something we refer to in the guidelines as very low mechanical index imaging, which brings out the nonlinear activity from the microbubbles while still being able to cancel signal from tissue. And the way we can do that is at a very low mechanical index imaging, a very low mechanical index, we're talking about less than 0.2 mechanical index, the microbubbles already exhibit this nonlinear activity. While tissue, which is kind of shown in blue here, has a little bit of fundamental response at that very low mechanical index, the microbubbles will have both a nonlinear and a harmonic and a fundamental nonlinear response. In other words, they don't necessarily give the same signal back, but give either a harmonic or subharmonic signal that can be detected by the transducer. And we can simultaneously cancel out any linear response from the tissue and get an exquisite kind of background subtracted image of just the microbubbles passing through first the left ventricular cavity and then into the myocardium. And the way that looks is here. This is one example of that where we're giving a contrast injection here, and you can see at 1.1 mechanical index, there's no signal from the myocardium here. Okay, because that's basically responding in a linear fashion, and these techniques now detect nonlinear activity from the microbubbles. So we see them approach the left ventricular cavity, and then we get good endocardial border delineation, and then myocardial pacification. So that we're purely looking at just the signal of these free intravascular tracers as they transit first through the left ventricular cavity, where we get the benefits of regional wall motion assessment, and then in the myocardium, where we can assess myocardial perfusion, both myocardial blood volume and myocardial blood flow. There are a few little adjustments you need to make to your scanner when using this technique. You need to optimize the near field gain. In other words, the time gain compensation needs to be set slightly higher in the near field. And then we deliver brief high mechanical index impulses to destroy the microbubbles, which is what they do at that higher mechanical index impulse. And that clears the myocardium of contrast, and then we analyze that replenishment phase for both wall thickening, to look at wall thickening and endocardial border delineation, as well as myocardial blood flow. So in that setting, it's critical, as we said, to see all the segments, and we think we can now see that even better with this very low mechanical index imaging technique. And others have used this now for quantification, not just for myocardial perfusion, but also to better delineate regional wall motion. And this is a multi-center study that has looked at left ventricular ejection fraction. Here's an example of a case I just saw last week where the resting echo was referred to me in clinic to evaluate left ventricular ejection fraction and assess the patient's functional capacity after bypass surgery and revascularization for multivessel coronary disease. And one of the key things was, did the ejection fraction improve? And if you have to make that assessment on an image like this, you can see how difficult that can be, especially when you're reading 35 to 40 of these a day. And the value here of using the very low mechanical index imaging technique is that it allows us, you'll see here in just a moment, to not only visualize the apex and these segments that can't be visualized, but also to look at the myocardial perfusion. And I'll show you what that looks like here. Moving really slow. Okay, so here now is that same patient where we've just infused, in this case, Definity, which is one of the commercially available ultrasound contrast agents. And you can see nicely the myocardial pacification, but much more exquisitely you can see the endocardial borders, okay, and pick up this mid-lateral wall motion abnormality that really wasn't evident at all on the non-contrast study. And certainly much better quantify left ventricular ejection fraction by whatever technique you want to use. We typically use a biplane method, and you could use three-dimensional echo with this as well. And again, this two-chamber view here, and again you can see there's that high mechanical index impulse that clears the myocardium of contrast, allowing you to get that very exquisite visualization of the endocardial border. And that's helpful for both quantification of ejection fraction as well as detection of regional wall motion abnormalities. Here's again that three-chamber view in this patient without contrast. and then with contrast, where you can see very nicely the endocardial borders. And this is the multi-center studies that I referred to earlier, which looked at non-contrast echo, contrast-enhanced echo, cine ventriculography, and magnetic resonance imaging to see which was the best at picking up regional wall motion abnormalities and which was the best at quantifying left ventricular ejection fraction. And in the assessment of regional wall motion abnormalities, which were adjudicated by a panel who knew the patient's history, and then these were blinded reads of detection of regional wall motion abnormalities, the contrast-enhanced echo had the highest accuracy for detecting regional wall motion abnormalities, slightly better than MRI, better than cine ventriculography, and certainly better, 10% better than unenhanced echo. Again, because it can visualize all these segments, especially when you use a very low mechanical index image, where you can better visualize the apex. And it's here, again, also where we are getting better detection of abnormalities when using this very low mechanical index imaging technique. Here's an example of a patient just a couple weeks ago that we had referred to us, had a prior infarction and was referred for a stress echo. So on the resting images, the question is, where is that prior infarction? And again, I apologize for this playing at the slow frame rate here. But the sonographer felt these images were fairly good quality, but we routinely use contrast for our stress echocardiograms for both perfusion and wall motion. And you can see, although this looked fairly well delineated apical two-chamber here, when we use contrast, we get this better visualization of the apex because, one, we're using that very low mechanical index imaging technique so that we're not destroying the microbubbles in the near field, and we're enhancing that nonlinear activity because we're looking at both in this Phillips system that we're using here. It detects both the fundamental and harmonic nonlinear activity. So this apical wall motion abnormality right here was delineated that wasn't seen on the non-enhanced echo. And again, these are playing at very extraordinarily low frame rates here, and I apologize for that. Here's another example of a patient in the emergency room with an acute stroke and who had a troponin elevation. And therefore, an echo was ordered for looking at regional wall motion. It appeared there was maybe some distal septal and apical wall motion abnormality here on the unenhanced echo. And what the sonographer did in this particular case here was use the low mechanical index imaging technique that I talked to you about originally, and then the very low mechanical index imaging technique that takes advantage of this non-linear fundamental activity of the microbubbles. And again, you can see how much better the apex is delineated here on these images, and delineation of a thrombus in the apex here, this contrast void area here where there's obviously no vascularity in a thrombus, so you can see how it has absolutely no activity there, but look how well it's visualized with the very low mechanical index imaging technique, where it was only partially visualized when using a low mechanical index imaging B mode method shown here, and certainly almost invisible on the unenhanced echo. And so in this setting, visualization of the apex is critical, and the very low mechanical index imaging techniques help us delineate that. Here's another example where the fellow was doing this echo, and it was a patient referred for chest pain in the acute setting, had known coronary artery disease, prior apical infarct, and it looked very much to them like a thrombus in the left ventricular apex, but contrast was ordered to try to better delineate that. And now what I'll show you here, this is using the Siemens contrast pulse sequencing, which is, again, another very low mechanical index imaging technique. All these vendors have their very low mechanical index imaging technique. And this is when the contrast first appeared in the left ventricular cavity. And then, as you can see, about 1 beat after that, we see contrast entering in through a narrow neck here in the apex. And then when it opacifies the myocardium, you can see no opacification of this portion of the apex. And then in this area here where there's a narrow neck, the contrast is actually moving into another cavity in a walled-off area of contrast beyond the apex here. This is a pseudoaneurysm of the apex. Here's the neck. Here's the contrast entering into that pseudoaneurysm, and here's the infarcted apex, which obviously has now no contrast enhancement in it. So you can see how diagnoses are changed in this acute setting when you use the very low mechanical index imaging technique. And this is some studies that have been done. You're all aware of the fact that there was a box warning on use of contrast for a while, about in 2008, because there was some concern that contrast had some potential anaphylactoid reaction with it, which turned out to be about 1 in 10,000. The good thing about the box warning from the FDA is that it caused us to do large studies to look at is contrast safe, like in the intensive care unit. And this is some work from Mike Main in Kansas City, where they took the Premier database and looked at patients that got contrast, the mortality of patients that got contrast within the first 48 hours of hospital admission in a critical care setting, like the examples I just showed you, versus patients that were propensity matched. Obviously, this is a retrospective study, so you have to propensity match the patients to different comorbidities. So they matched them to about 7 different associated conditions that may also affect mortality. But in all these settings, the patients that had contrast, which is shown here in the pink, had lower mortality than the ones that did not get contrast, okay? So it turned out to be the opposite, okay, of what the FDA was concerned about. The use of contrast early in the acute setting actually has been associated with improved outcome. Perhaps because we're making the diagnosis sooner, and you see how it changes the diagnosis when you use the very low mechanical index imaging technique. In spite of that, he's playing games with me here. Move back. How do I move it backwards? There you go. Previous. There we go. Let's use that. What? Go back a few slides here. The current contraindications by the FDA, a lot of these have been removed in the last 6 or 7 years after we've shown that it's safety in pulmonary hypertension, it's safety in acute care settings, like I just showed you in the Premier database. They still consider right to left shunting a contraindication, though we know that 25% of us in this room and in this world probably have a little bit of right to left shunting from a patent foramen ovale. We do not consider that a reason not to give contrast. Any hypersensitivity to blood products with the Ultrasound product, because that has an albumin shell, would be a contraindication to using contrast. And this anaphylactoid reaction that it typically is associated with any lipid encapsulated microbubble seems to be about 1 in 10,000 cases. I've been using Definity for about, since it was approved in 2001, and so we have probably about 25,000 cases. We've had 1 anaphylactoid response, but we still carry resuscitation equipment and have epi available because it does respond to that. But it should not really be used as an excuse not to have a policy in place for contrast use in your hospital because of the dramatic benefit that we see. And this is looking at all the 3 approved agents in this country. Lumason was just approved a year ago. Although the agent is also called Bracco in other countries, excuse me, not called Bracco, Sonaview in other countries, but again, the safety data on that has been published and is not shown any adverse effects. This has been the hospital records from Europe. The Definity data I showed you, Mike Main's data, which has actually shown a protective effect to using contrast. And then the Ultrasound database, which also has shown no adverse event risk associated with using it in large numbers of patients. There are other areas where contrast is helpful. Doppler enhancement, and clearly is helpful for picking up signals in the far field. Is being used more and more for vascular imaging, for carotid plaque detection, and for assessment of plaque neovascularization. And in TEE, it's used now more and more for left atrial appendage evaluation in cases where there's questionable thrombus. As I said, we're using it frequently now for perfusion imaging. There's a CPT code just approved for perfusion imaging with echocardiography with contrast. And clearly we need some multi-center investigation here, but I'll show you some data tomorrow which really shows the added benefit of using that during stress echocardiography and in this assessment of chest pain patients. I'll show you some examples here as well. Here's just an example of a patient that had a pulmonic valved conduit put in for a stenosis following a Ross procedure, and had some recurrent symptoms, some right ventricular enlargement, poorly visualized left ventricle. So contrast was used to better delineate that, but the sonographer also used it to better detect whether the gradient across the pulmonic valved conduit was normal. This is what it looked like without contrast. Then when we gave during the Ultrasound infusion, you can see we picked up a much higher velocity signal that actually turned out to be a stenosis in the distal portion of this graft by CT. And we wouldn't have picked that up if we hadn't done the Doppler enhanced echo. This is that patient I showed you earlier that we were asked to evaluate his ejection fraction following bypass surgery. And what's nice about this is when you're done using it to image this, what residual contrast is left you can use to enhance your TR jet, which we couldn't get on him either until we used contrast, again using a lower gain setting, but we could easily pick up the tricuspid regurgitated jet to evaluate their pulmonary artery systolic pressure as well. And then, as I said, and we'll talk about this more at Echo Conference tomorrow, you can use the myocardial perfusion technique. And one of the unique things about perfusion with echocardiography in the microbubbles is that you can analyze two things. You can give that high mechanical index impulse, like I showed you, that clears the myocardium of contrast, and then you can analyze the replenishment. That rate of replenishment is proportional to red blood cell velocity. The plateau intensity is proportional to the capillary cross-sectional area, which, because of the inherent background subtraction we get with the very low mechanical index imaging technique, we can see that and measure that and quantify that. The velocity times a cross-sectional area is a flow. So we can, bedside, without radiation, analyze myocardial blood flow. And these are techniques that have been validated now, actually initially proposed by Kevin Way in 1998, have been validated as myocardial blood flow techniques, especially helpful during vasodilator stress, because nuclear in that setting only looks at myocardial blood volume, which is less sensitive for detecting coronary artery disease, while you get myocardial blood flow techniques. And the studies I'll show you tomorrow have shown how much better that is than nuclear at predicting patient outcome. However, it's also useful in just evaluating these patients with chest pain that have non-diagnostic EKGs. Here's an example of a patient that had a recent PCI of her circumflex marginal vessel about a month earlier, returned with some chest pain, no changes on EKG, no troponin elevation, but an echo was ordered because her symptoms were similar to what she had had prior to the percutaneous coronary intervention. You can see the echocardiogram without contrast, again, fairly good quality. Again, I apologize why these are playing so slow, I don't know, but the wall motion was initially interpreted as normal, but because of some rib artifact here, we did contrast with the very low mechanical index imaging technique. This is the four-chamber without contrast, and then when we play the four-chamber with contrast, we could pick up very nicely this mid-lateral wall motion abnormality. Right here, mid-lateral, again, not only is there a wall motion abnormality here that we couldn't see without contrast, but you can see there's no perfusion in that segment either, no replenishment following that high mechanical index impulse. Playing at this extraordinarily low rate, it's actually easier to see that perfusion abnormality. This wasn't evident on the two-chamber wall motion, looked essentially normal. So because of that abnormality in the mid-lateral segment, we went back to angiography, and you can see the circumflex stent had occluded. Again, creating a focal wall motion abnormality in the mid-lateral segment that was detectable only with the very low MI imaging technique with contrast. And Kevin Way, as I talked about previously, has used this in a little over 1,000 patients in the emergency department to look at regional function and myocardial perfusion. And when he saw patients that had with low TIMI risk scores and before any troponins were back, If they had normal regional function, normal myocardial perfusion, their outcome was excellent, even up to 24 months. If they had abnormal regional function but normal myocardial perfusion, in other words, they had perfused that segment that was ischemic, their outcomes were slightly better but significantly worse than those with normal regional function and normal myocardial perfusion, while those that had both abnormal function and perfusion, like the example I showed you, had the worst outcome and were probably the high-risk patients. And this can be identified right when the patient arrives in the emergency department, which will help us, again, like we said, in better stratifying these patients. These were the patients with higher TIMI risk scores, and you can see, even though they all have a worse outcome, as you might predict from the TIMI risk score, again, normal regional function, normal perfusion was a much better outcome than abnormal regional function and abnormal myocardial perfusion. Even when these patients got revascularized, their outcomes were significantly different. Again, showing the importance of assessing both regional function and perfusion at the bedside in risk stratifying these patients. And this is data we have from dobutamine stress echo in 788 patients that we had followed over a period of 4 years. Again, looking at the value of perfusion and wall motion, there are certainly circumstances where wall motion can be normal during a dobutamine stress study, but you have abnormal perfusion, abnormal replenishment following that high mechanical index impulse. And in that setting, these patients do worse, even when you consider in revascularization as a time-dependent covariate. Again, if both are abnormal, you have your worst case scenario. So in these settings, we think just using contrast, and forgive me for adding in the perfusion information a little bit this morning, but in these settings, just getting good regional wall motion assessment with contrast, using it for that FDA-approved indication, we improve patient care, and there are now multi-center studies and large single-center studies that have validated that. So in ultrasound enhancing agents, just for the case of improving LVO, we can change really the face of echo by changing it from a good technique to a reference technique. Not only because we can do excellent regional wall motion at the bedside, but we can do perfusion when using very low MI imaging. We need more IV starters. Our echo labs need more IV starters. We're pushing to get sonographers to start their own IVs and give the contrast so that it will facilitate this, but in labs that have this up and running, usually there's no reduction in throughput, but you really do have to adequately staff your lab for IV starters, and we clearly need more educational efforts to get people using this technique. It's an outstanding perfusion imaging technique that allows us at the bedside to look at both perfusion and wall motion, and this is kind of the dream of the cardiologist, okay, that I can at the bedside look at perfusion and wall motion simultaneously. And we need to overcome whatever administrative and cost barriers that are preventing us from doing that. Now, as I said, the first part of this talk, I wanted to talk about just those diagnostic applications. But I want to give you just a little update, since we're not just all imaging people in the room, on potential therapeutic applications using the same techniques, okay? It still can be done with a diagnostic transducer, okay? And I want to show you that data. With a diagnostic transducer, the same diagnostic transducer that delivers those high mechanical index impulse, there are numerous small animal studies and now some large baboon studies that have shown it can target drug and gene delivery, most notably gene delivery. And then I'll close with just talking a little bit about its potential for targeted thrombolysis because of its ability to do this, not only enhancing lytic agents, but it can be a primary thrombus dissolution agent. It's not enzymatic, it's just a mechanical effect that gives us targeted thrombus dissolution. So it can be used when you can't use a lytic agent. You can use this as a modality, and it can be done with a diagnostic transducer. That's what we're showing in Brazil right now. So the agents that can be used with the ultrasound in this setting for the targeted thrombus dissolution can be done with the commercially available microbubbles. For targeted drug and gene delivery, as I'll point out in a little bit, you probably need some modification in the microbubble so that they can have a higher payload of the gene. In other words, since the DNA is primarily negatively charged, we typically need a more cationic bubbles. Most of the bubbles that are commercially available are neutral. But they take advantage of this technique that we know that goes beyond, when we go just a little bit higher than those very low mechanical index imaging techniques, we go to the above MI of 0.4, around 1.0, 1.2, we induce this phenomenon we call inertial cavitation of the microbubbles. And if you look at this on a 6 megahertz frame acoustic microscopy, we have these scanners, are about like 6 in the world, I think, that allow us to do frame rate imaging, optical frame rate imaging at 6 million hertz, okay? So that we can actually see what these microbubbles are doing as a function of time. And we see that they grow and collapse to maybe 3 to 4 times their original diameter. In that collapse process, they create fluid jets that will dissolve thrombi. But also this will cause release of any agent attached to the bubble because they basically fragment. And in that setting, they release whatever payload they have on their the surface or carried inside the microbubble as well. And the initial experiments that have been done with that have demonstrated that you can deposit, this is one frame from a 2.3 megahertz transducer. I think I went back. What is this previous? Here, this is one frame from a 2.3 megahertz diagnostic ultrasound transducer during an optosound infusion. Now, this is an exposed spinal trapezius muscle, and so there's no attenuation of the ultrasound beam. But you can see that when that ultrasound causes that microbubble to do that inertial cavitation process, it does rupture that endothelium, and you get this zone around the capillary of some hemorrhage, okay? Now, we're not interested in inducing that. But if we attach, let's say in this case, just for the purposes of showing, these are 503 and 205 nanometer polymers that were attached with the microbubbles here. You can see the extent of distribution of that polymer, which are shown in red dots here, around that capillary. So you get a fairly large delivery of drug here for one capillary rupture, okay, induced by that capillary, by that inertial cavitation. And that has been subsequently used to see how well could we deliver just reporter genes. And this is some work from Paul Grayburn in Dallas, who has shown that with just a reporter gene here that colors the myocardium, if there's effective transfection of the agent, he did transthoracic imaging with a 1.3 megahertz diagnostic transducer, applying intermittent high mechanical index impulses to cause that cavitation of the microbubble, and showed fairly efficient transfection of the whole myocardium here with a perfluorocarbon microbubble. So this has subsequently led to seeing whether we could deliver effective genes, and this is some early studies looking at the use of just Definity, which is commercially available microbubble, delivered with some stem cell homing devices in post-infarction rats, where again they did transthoracic imaging with high mechanical index impulses, 1.6 mechanical index. The FDA limit is 1.9. And in this case a Siemens transducer, and showed that they could get stem cell homing genes deposited and transfected into scarred areas in and around the myocardium, and that resulted in some increased vascular density with repeated delivery of these stem cell homing devices and targeted transthoracic imaging. However, as I said, a neutral microbubble like the commercially available microbubbles are probably not the most effective means of doing that because they don't carry these negatively charged DNA particles on their surface. But plasmids that are constructed to attach to cationic microbubbles, and with some small modifications in the surface of the microbubble, you can make them positively charged so that they bind a lot more of these cationic microbubbles, or of the anionic DNA, or the negatively charged DNA. And that surface does lend some protection as well. In other words, circulating DNases seem to be prevented from destroying them prior to getting to their target. So they reach their target better when they're cationic microbubbles, the DNA that's attached to these cationic microbubbles. And therefore, when hit with ultrasound and they have this inertial cavitation phenomena, you get better payload delivery. And so this has been used in two different areas. One, this is again back at Paul Grabern's work, who has gone from using reporter genes to testing whether he could recreate the pancreas, okay, in streptozotocin treated rats. You can see the beta cells in the center of the pancreas, and then the alpha glucagon producing cells out in the periphery. And you can see after treated with streptozotocin, you can pretty much get rid of all the beta cells. And type 1 diabetes, is basically a beta cell deficiency. Okay, and so what he has shown with the group he's working with there, he's found a promoter that when delivered, attached to the microbubbles, to regions where the pancreas is in these streptozotocin treated rats, he can recreate the structure of the pancreas and effectively restore beta cell function and insulin production. As you can see here, this is the blue. These are the streptozotocin treated rats here. This is the control rat here. You can see in the one that had this neuro-D promoter delivered with the microbubbles that their insulin production was restored at day 30. And then he's subsequently now taken this to the baboon model with diabetes, where obviously there's some attenuation of the diagnostic ultrasound beam, but still effectively is showing that he can, even in this larger animal model, get a restoration of the glucose tolerance test in streptozotocin treated baboons after using that same promoter attached to microbubbles and delivering that. So he's very close, I think, to getting that into the initial human trials. This is some work from Howard Leong Poi in Toronto, who's also used it to treat limb ischemia and has shown that a microbubble method of delivering VEGF more effectively restored the skeletal blood flow in an ischemic limb. This is a ligated limb where he's actually delivering the VEGF DNA plasmid attached to cationic microbubbles and comparing it to intramuscular delivery. You can see that with the systemic delivery and targeted ultrasound, have a more uniform deposition of the VEGF and eventually a better flow reserve at 28 days post-limb ischemia. He subsequently has shown that by giving it targeted VEGF and then angiopoietin at a separate time later, that they get the best restoration of blood flow and blood flow reserve when using this kind of dual delivery system, again, attaching cationic microbubbles to two different agents at two different time points to get a restoration of limb ischemia. And finally, in the area of targeted thrombolysis, again, here we're not talking about targeting any drug attached to the microbubble. We're just trying to take advantage of that pure mechanical effect of inertial cavitation, where if we apply that while the microbubbles are transiting through a thrombus that appears angiographically occluded. And this is one of the things we've observed, is that although angiographically these vessels appear occluded, there are still small channels that we can pick up with these very low mechanical index imaging techniques. And as these microbubbles transit through there, then we hit them with that high mechanical index impulse that causes inertial cavitation, and we believe that can potentially restore flow. And what we did is we initially tested that in vitro, and this is some work from Christy Holland in Cincinnati that shows how that concept is important. What you'll see is, I'm going to start this video in a second, we're going to turn the ultrasound on and then off. In other words, we're allowing microbubbles to replenish this region. This is a tubing with a completely occluded thrombus in it, but we still see that microbubbles will channel through this. Then we turn the ultrasound off for a few seconds, and you'll let microbubbles replenish this region. Then we hit it again with high mechanical index ultrasound, and you'll see what happens to the thrombus. So there, the bubbles are going in there, then they're getting hit with the ultrasound. Now hitting back again, and we turn it off here for there's off. Now the microbubbles are replenishing, and we turn it back on. And you see over time, which is along the x-axis there, you see this thrombus is gradually dissolving, just by the pure mechanical effects of the inertial cavitation. And so when we tried that initially in an occluded dialysis graft in a canine model where we used a 1.6 megahertz low mechanical index imaging. And this graft appears angiographically occluded. We did this with Bill Culp in interventional radiology. We can still see a small channel of microbubbles. Those white lines are the ultrasound high mechanical index impulses. Now it's off, and now you see with low MI imaging the replenishment of microbubbles in that small channel, and we turn the ultrasound back on, and that then causes those bubbles to cavitate. Well, this is 0 to 3 minutes into that treatment. Then if you go down and keep doing that, by 12 to 15 minutes, see what happens to the size of that channel. The channel is much bigger now because that cavitation process has gradually dissolved the thrombi. And this is all being done when we tried this with just diagnostic high mechanical index impulses in this vein graft, or excuse me, dialysis graft. You can see that by 30 minutes, we had almost an 80% angiographic recanalization rate, just applying those intermittent high mechanical index diagnostic pulses into the graft. So the next step was, can this potentially be used in acute ST segment elevation of myocardial infarction? In other words, as a quick early treatment modality that could hopefully, as we said, applied in the ambulance to get restoration of not just epicardial flow here, but microvascular flow. As you know, that's still a major problem. Either I have spastic hands or these slides keep moving back forward. I'm sorry about this. About previous. 35% of the patients that get good timely PCI, okay, only 35% actually get good microvascular flow, okay? And so there's still a problem here, even when we do optimal therapy in terms of getting microvascular recovery of flow. And that, as we know, is a major problem, okay? It's not only an arrhythmic substrate, it's probably the mechanism by which the adverse remodeling that leads to heart failure and need for a defibrillator placement starts its process. So we said, well, potentially, if we image the microvasculature, obviously with transthoracic ultrasound, we can't image the coronary vessel, but if we image the microvasculature, and when we see microbubbles replenishing that microvascular zone in acute setting and applied high mechanical index impulses to both the epicardial and microvascular regions supplied by that vessel, could we restore epicardial flow and could we get better microvascular flow? And this is a atherosclerotic pig model that we tested this in, and we were able to demonstrate that with some slight modifications, using slightly longer pulses than what are typically used for diagnostic ultrasound, we could improve wall thickening within that risk area with just 30 minutes of treatment of that ultrasound and microbubble treatment. With the ST segments would recover, and the control group is a half-dose TPA here in an LAD occlusion model here in this pig model, and then transthoracic imaging. But more importantly, we were able to get the epicardial vessel open within 30 minutes in about 80% of these pigs that were atherosclerotic and had acute ST segment elevation myocardial infarction in the LAD territory. So this seemed to provide evidence that applying these intermittent high mechanical index impulses to the microvasculature could potentially be used to not only restore microvascular flow, but potentially get the epicardial vessel open earlier. So we had slow processes in this country getting the FDA to approve this for the drug because they wanted to switch it to a device. But in working with Wilson Mathias in Brazil, we were able to get their government to sponsor the study, their NIH equivalent, to sponsor a clinical trial with this, as well as Amsterdam now has had it approved in the Netherlands. But the whole project was based on the fact that if we take the diagnostic system, now unfortunately they don't have a small system yet. This is our hope that we can get this put on like the CX50 or something like that so that we can get it in the ambulance, because obviously the sooner we can get it, the better. But right now they're just applying it when the patient arrives in the emergency room in Sao Paulo, and if they have ST elevation MI, and I don't think I have a picture of this here, but it's a kind of a chaotic setting there. because they have just a cardiac emergency room, and it's just beds lined up for about 3 or 4 hallways. And then there's a little notebook there that says STEMI, aortic dissection, chest pain, acute coronary syndrome. So you just kind of go in there and find the STEMIs. It's pretty chaotic. Though their labs are great, it's just that the ER is pretty, not that well developed yet. But it is a good setting to have a lot of STEMIs, okay? And it does give you a chance to get this done, because right now all we have is the big ultrasound system with the that's capable of giving these high mechanical index images and the low MI imaging to look at the risk area. So these patients are randomized to either just the emergent PCI alone or the intermittent high mechanical index impulses with just intravenous Definity applied for whatever time we can before they reach the cath lab, and then for about 20 minutes after the stents placed for any microvascular debris that still may be present. And we used, Philips was able to give us that longer high pulse sequence, but we compared that with just giving the standard high mechanical index impulses that are available for diagnostic imaging. And that, in this case, we just had them apply these standard high MI impulses in the 4-chamber, 2-chamber, and 3-chamber view while they were going to the cath lab, and compared that with the slightly longer pulse duration impulses that would be that Philips made available, and then compared to the control group. And this is the pilot study that we presented at the ASE this year. And in that setting, when by the time they got to the cath lab, 80% of the vessels that were treated with just the standard high MI impulses in the 4-chamber, 2-chamber, and 3-chamber views had recanalized by the time they got to the cath lab. And it was even actually better than this non-standard longer pulse duration, which we've actually seen. This probably doesn't add anything, potentially may aggravate the issue a little bit by causing some spasm. And so this seems to be the real winner here in terms of just giving those standard high mechanical index impulses in the 4-chamber and 2-chamber and 3-chamber views in terms of epicardial recanalization. Here you can see how it affects the microvascular flow. This is a patient that just, when they got to the emergency room, had acute ST elevation, V2, V3, V4. The apex clearly had no microvascular flow, but with just the first 10 to 15 minutes of using the high mechanical index impulses applied, the diagnostic high mechanical index impulses applied to the apex, we were restoring microvascular flow, and by the time they got to the cath lab, the LAD was open, and then you can see following PCI, there was complete restoration of flow. But again, a tool that potentially could be used early in the setting to restore microvascular flow may help us get better microvascular outcome, and that's what we're trying to achieve. This can be used in other settings, okay? We've shown in acute ischemic stroke model, in that same PIC model, transtemporal diagnostic high mechanical index impulses restored cerebral blood flow. Shelby Cuddy, our pediatric cardiologist, has used this for catheter thrombi, for chronic indwelling catheters that develop thrombi on them, and showed that they could be dissolved with repeated high mechanical index impulses. And he also showed that in grafts that are placed, the typical grafts that are used sometimes for palliative therapy in early congenital heart disease, by just applying these high mechanical index impulses to these grafts intermittently for every couple of weeks, they could prevent them from thrombosing, because they tend to form fibrin on them fairly early. So I think you can see this application covers a wide range of potential areas, certainly areas that we need more input and research in. But if we just optimize LVO, I think we can improve the care of the patients we see in the critical care setting. We can do better stress echo, especially if we add perfusion to that. We can better quantify ejection fraction and better visualize the apex, especially if we use the very low mechanical index imaging techniques. Myocardial perfusion imaging, this could be, in my opinion, a better way of doing myocardial perfusion imaging than SPECT, because it allows us to look at myocardial blood flow. It gets us to the PET area, but allows us to do it at the bedside, okay? And then the areas that I think will be evolving in the next 3 to 5 years will be the targeted thrombus dissolution and targeted gene delivery, where we can potentially not only have a diagnostic impact, but a therapeutic impact in preventing some of the microvascular problems that persist in spite of our current state-of-the-art therapy. Thank you.
Thanks, Tom. That was fantastic. I'll start off with one question about the targeted gene delivery. So it's clear that you can target it. What about off-target effects, though? Because where would any of the bubbles, the microbubbles that aren't lysed, where do they end up? And since you've got DNA sort of on the surface, is that a problem with the liver or other end organs?
Yeah, I know that Paul Grayburn looked at other organs, outside the insulination field, and there is still some liver uptake, because that's the kind of final dwelling place of microbubbles in a lot of places, but none of the other organs exhibit that. As long as they weren't hit with a beam, then there wasn't any deposition. So it seemed to be fairly targeted to the area where you applied the ultrasound.
Other questions from the group here? You have any? We got it over here. Can we get Rebecca the microphone, please?
In terms of other things that are naturally in the body that are similar size, are they affected at all by the ultrasound beams, like exosomes or even cells? Will those things also rupture?
If they don't have the microbubble, and it's the microbubble that seems to be the most sensitive to that. Anything with a nucleus in it, a nucleus of air or gas, I should say. Obviously, cells have a nucleus, but I mean anything that's the one. So if a microbubble is engulfed, like a phagocyte, then that phagocyte could potentially be disrupted by that. The other thing is that cavitation process. What's interesting, and Jonathan Lindner has shown some of this work, is that same cavitation process along the endothelium results in a fairly large nitric oxide release. If that occurs near the endothelium. So he's shown some fairly large nitric oxide release with the targeted ultrasound. If you repeatedly apply that, you can cause, there is a dose response curve. If you go to a high enough mechanical index and apply it to that same region long enough, you can cause capillary hemorrhage. So it's definitely, a brief effect seems to be that what you want to try to achieve. That's what we saw also with the 20 microsecond pulse. So normal ultrasound is about somewhere around 2 to 3 microsecond pulse duration. And when we use these very low mechanical index imaging techniques, they can they go up to about 4 microsecond. But if you go up to 20 microsecond, the Amsterdam group has shown that in this acute MI setting, they're seeing some vessel spasm. So you can release some mediators that are vasoconstrictors potentially as well. So it's clearly something where you have to control what you're delivering.
Have you looked at the microvasculature in the pigs in your model after you've opened things up?
Yes, we have done that in a couple settings. One where we actually took different tissue mimicking phantoms and applied it just to a skeletal prep microvasculature, but also in the coronary microvasculature we have two. It seems like when you have an attenuation there and you apply these brief 5 microsecond pulses, we don't see any pericapillary hemorrhage, but you will see some pericapillary hemorrhage with the longer pulse duration, especially if you use something like L-NAMI, something that inhibits nitric oxide production. The nitric oxide production that also accompanies the high mechanical index impulses seems to prevent some of the capillary hemorrhage, probably because it affects the red blood cell kinetics a little bit.
Great talk. Do you do rest perfusion in every patient?
Yes.
Do you have a protocol?
Yeah, because we usually pick up abnormalities. In fact, in the prospective study that we'll talk about tomorrow, where we looked at about 2,000 patients, where we randomized them to stress echo, where they were referred for stress echo, and then we randomized them to just conventional stress echo, where contrast was just used for the FDA-approved indication, versus perfusion imaging on everybody. Identification of a resting wall motion abnormality with very low MI imaging was the single most important predictor of outcome.
So you have trained all your sonographers to do that by themselves?
Yeah, they do that for all their studies. Even the rest studies up on the floor, right? They just do this very low MI flash replenishment.
And do you report in your reports, do you put the rest perfusion findings?
Yes.
Last one.
Great talk. I have a question about that group of patients who have no wall motion abnormalities but abnormal perfusion. Have you combined that with CFR?
No, but Nicola Gaibazzi has done that in Parma. Now, in Italy, they just use diperidomal stress perfusion imaging, but he's looked at stress wall motion, diperidomal stress wall motion, stress perfusion, and coronary flow, and the LAD. Primarily in the LAD is where they do their flow. Both the Doppler flow and the perfusion added additional information to the wall motion. But perfusion was the one that added incremental value because they could look at the inferior and lateral segments and detect abnormalities there, while they had trouble picking up circumflex and RCA Doppler flow with the Doppler, the transthoracic Doppler. Now we have compared, one of the other things is we have compared FFR with the myocardial blood flow imaging, and we're seeing about although if FFR is abnormal, we clearly see an abnormality by the perfusion echo, but there's a significant number of cases where we see inducible perfusion defects and wall motion abnormalities despite FFR values greater than 0.8. And that to me is an area that really needs to be looked at more.
Real quick.
Just to be sure you let folks know he's talking tomorrow.
So, okay. Well, again, thanks so much for a fantastic talk, and we're going to look forward to your visit, and we'll hear your talk tomorrow morning again. Welcome. Thank you very much.
The preceding program is copyrighted by Emory University.